Welcome everyone to the ADNeT Memory Clinic webinar series. I'm very excited. This is our fourth webinar that we've done so far. I'm even more delighted that this particular topic is very close to an area that I've been interested in for many years. So very pleased and proud to present this first interventions for older adults. Summarising the evidence, the examples, and moving towards implementation, hopefully throughout the ADNeT Memory Clinic network in Australia one day. For those of you that may miss some of this, we will have a recording of the webinar, as well as previous webinars that are available on the ADNeT YouTube channel, and the address is here. So I'm delighted that we have two fantastic presenters today, which I'll introduce in due course. But just to start, I'd like to formally acknowledge the traditional custodians of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to all Aboriginal and Torres Strait Islander peoples, their cultures and to their elders past, present and emerging. Just for those of you that are new to join our webinar series and are wondering what ADNeT is all about, ADNeT is a national network that received from NHMRC a couple of years ago, as well as philanthropy. And we're a network of national dementia research experts. We have three key components of our initiatives. The first one is the ADNeT Clinical Quality Registry, which you may have heard about. The other one is ADNeT Clinics, which is us, where we're aiming to develop a national memory clinic network to provide people with dementia with a standardised package of clinical assessment and care and improve the linkages and access. So as part of our remit, we'll be producing guidelines, which many of our clinicians have been involved in, and we're very grateful for that. We're also producing training packages and also aiming to make ourselves more accessible and to improve the health services and particularly post-diagnostic care for people with MCI and dementia. The other important aspect of ADNeT, which you may have heard about before, is the clinical trials and cohort studies. So we now have trial sites in most areas of Australia, most states of Australia, with many of them actually live and already recruiting. And this is really important in terms of getting access to the best diagnostics as well as access to clinical trials. And our packages are supported by ADNeT Tech as well as ADNeT Business, with an aim to be able to sustain the ADNeT network beyond the term of the 5-year grant. And so just quickly to talk about the ADNeT registry, this is a really important initiative. It's something that we'd like to tell you more about in future webinars that we have. Essentially, the registry aims to monitor and drive the quality improvements in clinical care as well as outcomes for people with dementia and MCI. There are many clinical quality registries running around the world. In Australia, we now have 26 clinics that are signed up to the registry. It's headed by a wonderful, very passionate and caring team, Susanna O'Hearn, as well as Stephanie Ward, as well as Casey Wallace, and key people coordinating the network. I'm sure you'll hear about it in due course, but I think importantly, it gives you feedback about the quality of care that you are providing to patients and also how we can think about collectively improving our services nationwide. If you're interested in joining the National Memory Clinics and Services list, we're very keen to have you on board. We'd like to be able to post a kind of widget Google device on the ADNeT website so that GPs and members of the public can actually find our memory clinic services, whether they be public services or private services. And if you're interested in being involved in this, there is a short questionnaire that you could complete online, and also just get in touch with us if you want to know more about that. And there'll be more information about that in the chat that Joe is providing, as well as a link. Just quickly before we start, we have some housekeeping as usual, just to let you know that all the microphones will automatically be muted. If you do have any technical difficulties, then feel free to raise your hand button, which you'll see in your Zoom function, and one of our moderators will send you a private message to address your issue. If you have any questions, then use the question and answer button below and write all your questions in there. And you can also click the little thumbs up button if you see that someone else has already asked a question, and which will let us know perhaps to try we get lots of questions at the end. The other thing is we're very, very keen to improve the quality and the types of presentations that we provide via the ADNeT Memory Clinic's webinars. So if you can complete the brief survey at the end, that would be wonderful. It will open in your browser automatically after exiting the webinar. And this will give us feedback on the quality of the presentation, suggestions for future topics. And we will also send a certificate of attendance via email. So it's my great pleasure now to introduce our speakers. I just find their bios here, even though I know the first one very well. So our first speaker is Loren Mowszowski. She's a clinical neuropsychologist and an NHMRC ARC Dementia Research Development Fellow at the University of Sydney. She's actually Deputy Director of the program that I run at the University of Sydney, which is a Healthy Brain Ageing program, and she leads the cognitive intervention research stream within that. Her research focuses on developing and evaluating interventions targeting cognition, psychosocial functioning, and modifiable risk factors in older adults. And she has a more recent emphasis on clinical and community implementation beyond the research setting. So Loren's actually a co-chief investigator on 2 NHMRC funded research trials, which incorporate cognitive interventions. And so she's attracted more than $4 million in research funding to date. So she has 43 peer-reviewed publications and 3 book chapters across psychology, neuroscience, and psychiatry. It's my great pleasure to welcome Loren today.
Hello, everybody. Thank you so much for coming along to the webinar today. And thank you to ADNeT for giving Kerryn and myself the opportunity to talk through our work and through some ideas that Kerryn and I have been talking about for some time now. Before I begin, I would also like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water and culture. I am currently on the land of the Gadigal people of the Eora Nation, and I pay my respects to their elders past, present and emerging, and further acknowledge the traditional owners of the country on which you are on, and pay respects to their elders past, present and future. So through the webinar today, I'm going to start us off and then hand over to Kerryn a little bit later. And I think Sharon will introduce Kerryn at that point. What we'd like to do is start off with a bit of an overview for you of cognitive interventions for older people, some of the key concepts and approaches, and certainly a summary of the evidence in some key older adult groups that tend to come through memory clinic, the memory clinic context. So healthy older people, those with mild cognitive impairment and those with dementia. Kerryn and I would like to take you through our programs as examples of evidence-based and clinically developed cognitive interventions. And we'll also take you through our experiences to date in terms of translating those research programs and implementing them into the clinical setting and the community. We'll then talk you through some other experiences in implementation around the world, and then a discussion of some of the key considerations and the barriers and facilitators that we've discovered along the way in terms of implementation, hoping to then stimulate some discussion around where do we go next. Okay, so what are we actually talking about? What is cognitive intervention? For those of you who are not as familiar with it, essentially it's a non-pharmacological approach to intervention that's aimed at reducing or alleviating cognitive difficulties, and those may be perceived or objective cognitive difficulties. And ultimately, this therapeutic process is aiming to increase or improve an individual's capacity to process and to use information around them to increase their functioning in day-to-day life. Now, some key concepts that we want to set up our discussion today we feel are important to understand. First of all, this is a very heterogeneous field. So the terms that are used to describe cognitive interventions vary, the techniques vary greatly, there are different approaches and certainly different ways of investigating outcomes. And that does tend to muddy the waters, and it's something to bear in mind when you're engaging with this field. At the heart, cognitive intervention really requires an understanding of the relationships between the brain and behaviour, And we believe that it should involve, first and foremost, an assessment of cognition, but ideally an integration of other information available clinically as well. It's also important to understand that different interventions may have different targets, and we draw on the World Health Organization ICF framework for defining disability here to try and conceptualize different targets of intervention. So certainly some cognitive interventions will target impairment of cognition, and we'll look at outcomes around objective test performance in certain cognitive domains, whereas others might look at outcomes relating to day-to-day activities and limits or restrictions in participation as well. So outcomes there may look at things like self-efficacy or confidence, or perhaps even engagement or goal attainment. Typically, a cognitive intervention will involve either compensating for deficient cognitive processes, so using alternate skills to reach the same goal or complete the same task, or trying to restore those impaired cognitive functions. And for maximum effect, we know that the intervention has to incorporate the idea of internalization, so where those processes really become habitual and automatic, and also promote generalization, so the application of those skills or strategies or processes to other tasks and environments as well. And we know that the mechanisms of cognitive intervention most likely engage things like neuroplasticity, cognitive reserve, and also targeting psychological schema. So in older people, that would relate to challenging expectations or beliefs or attitudes around aging and around what one can achieve. So thinking about a very basic framework to try and understand those different approaches to intervention, I've just amended a framework that we presented some years ago in 2010, and this really shows you an overview of the different approaches. So you can think about cognitive stimulation, for example, which is quite non-specific. It doesn't focus on any particular cognitive domain. It involves things like reality orientation, reminiscence therapy. Cognitive training does involve repetitive practice on specific cognitive skills and may involve strategies or computerized exercises. And cognitive rehabilitation differs in that it's much more goal-oriented and focuses more heavily on functioning. So how does that individual actually complete day-to-day tasks and activities? And it can involve any of the other techniques utilized in cognitive stimulation or cognitive training. In terms of the evidence, there's been a veritable explosion of cognitive intervention research over the last decade or so. But that research demonstrates highly variable approaches in terms of the design of the studies, their quality, the types of controls that they use, the characteristics of the participants, the approach that the intervention takes in terms of what I referred to a moment ago, the various techniques that are used, and the outcomes can vary as well. So we see studies reporting outcomes on the tasks that were directly trained, as well as on what we call near transfer, which are improvements on non-trained tasks, but within the same cognitive domain, or far transfer, which is perhaps in other cognitive domains or in functional outcomes. So it's very important to consider the target of the intervention, as I alluded to earlier. This all makes it very difficult to synthesize outcomes across studies and across cohorts. However, despite that, there is a very solid body of evidence now in older people, and there are many good quality systematic reviews and meta-analyses that we will point you to draw on in analysing that evidence. So in healthy older people and those with MCI, a recent meta-analysis found that the cognitive status was not a moderating factor, so we can effectively look at those groups together. And generally, most of the analyses seem to show at least small, significant benefits for memory, for working memory, attention, speed of processing, and executive functioning. And that's mostly evident on trained and near transfer outcomes, but it's important to note that the effect sizes tend to vary, and that small but significant effects have also been shown in non-cognitive outcomes. Certainly, though, these tend not to be investigated as much in these groups, even though for participants, a lot of the research shows that those are the things that they actually value: quality of life, self-efficacy, functioning, and mood. And we've highlighted some examples of reviews down the bottom if you're interested in looking into this further. In people with dementia, a recent Cochrane systematic review by Alex Bahar-Fuchs down in Melbourne showed a small but consistent body. Sorry, I've skipped ahead too far. There's also a small but consistent body of evidence still staying in healthy older adults in MCI for neurobiological change, and it seems that the effects may be sustainable, at least in the shorter term. Some of the moderators of these cognitive effects seem to be shorter sessions are better than longer sessions. More than 3 sessions a week doesn't seem to add any benefit. The jury seems to be out around whether a facilitated versus a home-based or a group or individual approach has any greater effect. We would say from our experience that probably relates to things like adherence and motivation. And importantly, age does not appear to moderate capacity to benefit. And it's also important to recognise that among these samples, they're not particularly culturally diverse. They tend to be help-seeking, quite motivated, and quite well educated as well. So now, we can change to that systematic review in people with dementia, and that shows small to moderate effects on global cognition and verbal fluency, lasting in the medium term, but with the caveat that studies tend to be of low quality and very heterogeneous in people with dementia. Importantly, there are no adverse effects in this group, but really it seems to be that targets of interventions in people with dementia should focus more at that activity and participation level. And things that seem to work well for people with dementia are a goal-oriented approach using strategies such as procedural memory training, dual cognitive support, errorless learning, and spaced retrieval. There is some evidence for assistive technologies, things like using videos or timers or robotic pets for companionship, etc. But the quality of the evidence is not very high. Okay, so skipping now to show you some cognitive intervention in action. And I'd like to take you through our Healthy Brain Aging program here at the Brain and Mind Centre, which was really pioneered by Sharon Naismith. Some very brief background. We are a multifaceted clinical research program focusing on modifiable risk factors for cognitive decline. We see people over the age of 50 in our clinic with cognitive or mood change. And just to give you a breakdown, our participants are generally those with MCI or subjective cognitive concerns. So that's the greatest proportion of people that we see. The rationale behind our program was this idea that that cognitive intervention is probably most effective as a secondary prevention strategy. That is, it may have most benefit to slow progression, to prevent or delay cognitive decline in people that are at a higher risk of developing dementia. And additionally, we feel that multifaceted approaches to intervention may be optimal and may have a synergistic effect. So in terms of our program, we initially developed a pilot trial which was not randomized, and we were able to show effects on cognition as well as capacity to benefit from psychoeducation around those modifiable risk factors. We then looked at a randomized controlled trial of the program and showed cognitive effects and also some neurobiological effects as well. And we've adapted the program also to other cohorts, including people with Parkinson's disease. I'll just take you through the program in a little more detail. Its components include psychoeducation and cognitive strategy training and practice, followed by a tea break, which we feel is important for social engagement and support, and then an hour of computer-based exercises, which we follow the NEAR model, and I'll take you through that shortly. We have a 7-week course with twice-weekly sessions in a group format. And for our studies, we utilised a waitlist control condition, and we looked at a number of cognitive, neurobiological and psychosocial outcomes. So our psychoeducation component was quite multifaceted. As you can see, the first half focused heavily on cognition, unpacking it and going through various strategies that I'll show you in a moment. The second half focused on modifiable risk factors for cognitive decline, and we were able to bring in a variety of health professionals as presenters. So these are just some snapshots to show you how we presented the psychoeducation material, trying to keep it engaging, using both visually and verbally stimulating information. And the strategy-based component was essentially designed to build a toolbox of tips and tricks that our participants could use, where the clinicians are providing guided practice in these strategies and also emphasising things like repetition and consolidation, how it relates to the real world, providing homework, opportunities to practice and implement those strategies in day-to-day life, and then further opportunity to consolidate them through review and discussion at the next session. So just to give you an example of how we might use some of these strategies, if we look at semantic categorization, for example, we would introduce an exercise, take our participants through trying to encode as many of these visual stimuli as they could, and then discuss a strategy that might be helpful. So talking about things like chunking and retrieval cues and deeper level processing by attaching information to existing concepts and verbal recoding, all those kinds of things. We then relate it to an obvious everyday example. So here, of course, it would be a shopping list, and we would utilize this as another opportunity to demonstrate how that strategy can be helpful in encoding. Another example, if we look at information processing, these are some of the exercises we might use, but the strategies that we teach include things like a systematic and methodical approach, rehearsal, etc. And of course, relating it back to those everyday examples as well as to when those strategies might be helpful. The computer-based component of our program followed the neuropsychological educational approach to remediation. So here we used educational computer software with clinician facilitation and guidance, really focusing on learning and behaviour principles, things like graded difficulty, positive reinforcement. The thing with NEAR is that it's very much individually tailored and focused on an individual's strengths and weaknesses based on their neuropsychological assessment. So some examples of the computer programs that we used as a platform to demonstrate and teach some of those strategies and to target those specific cognitive strengths and weaknesses. We also utilised a therapy plan to help us individualise the program and invited patient feedback as well to increase motivation. So very quickly, some of our results. We were able to show in the first pilot trial in people with late life depression, improvements in verbal memory and visual learning, as well as knowledge regarding those modifiable risk factors. Of course, that was limited by not being an RCT, so we ran the program again as a randomised controlled trial with a waitlist control, and again, we're able to show improvements in memory as well as depression on the the geriatric depression scale, and in sleep quality as well, using the Pittsburgh Sleep Quality Index. And as I mentioned earlier, we've adapted the program to suit those with Parkinson's disease, and we're able to also show improvements in verbal learning and memory, and also for people with Parkinson's disease who experience freezing of gait. And that was a world first trial where we were able to show reduced freezing of gait and daytime sleepiness, as well as improved processing speed as a result of our program. So moving on now to thinking about how do we translate and implement this program. We've shown an evidence base for it, but thinking through how do individuals in the community usually access interventions. We know that it's either through a hospital or a community-based program, or perhaps even with private clinicians where it tends to be one-on-one. And so these are the kinds of questions we started to think about in terms of moving our research out of that research setting. And we have a number of approaches that we've embarked on. The first one is the CogMax study. So we have adapted our Healthy Brain Aging program to suit a one-on-one therapeutic context, or to suit self-directed, home-based independent completion. And so we've changed and adapted the program to a structured manual where people can complete the psychoeducation and the strategy training. And we're currently running an RCT to compare the two conditions. In terms of what we've learned about translation through this, the adaptations that we've had to make, we've added collaborative goal setting to try and focus more on some of those functional outcomes. We've had a significant change in the format and the style, obviously changing it from a series of PowerPoint presentations and an in-person group-based program to this manual. We've updated the evidence and also updated the exercises so that they rely less on group involvement. And in terms of the learnings that we've had, we found the adaptation was quite time and resource intensive. We were a little bit concerned about the loss of the social benefits from that group format, which we feel has always been a really important component in terms of motivation and normalization of experiences. But nonetheless, we've had a really wonderful response so far. We find that both the one-on-one facilitated version and the home-based independent completion are working quite well. And we haven't had any issues so far with adherence from the home-based group, although they do get a weekly check-in. So that research is ongoing, and we're hoping to see how that will allow us to translate this program in a fairly simple way, either to clinicians directly or directly to consumers. Our next approach was to adapt the program for online use. And this is an attempt to provide access to this kind of program to people who either can't access in-person services, perhaps they live rurally or remotely, for example, or who don't want to access in-person services. And so again, we've adapted the program following more of the CogMax structured format. And we're currently running an RCT, which is open to recruitment Australia-wide. So I have put our email address up there if you know of anyone who might be interested. Again, adaptations, we had to significantly change the format, content and style. And in terms of learnings, again, this was quite time consuming and resource intensive. Additionally, because we were now working with a software developer, we had to really work on communicating and engaging that new partner. We're a little bit unsure as to how we'll go in terms of adherence and the lack of support for behaviour change because this is an unmonitored intervention, but we're quite keen to see whether this could be an opportunity to provide that intervention to people who might not otherwise have that opportunity to access it. Our next foray into implementation has been led by Claudia Wolf, who is a wonderful PhD student at St Vincent's Hospital, working with the fantastic Older People's Mental Health Service. And she has really led an adaptation of the HBA program within that setting, adapting it for older people with late life depression, and actually following a formative evaluation using the implementation framework known as RE-AIM. And I've just listed here the key targets that RE-AIM aims for. So it's a change in the way we view outcomes of this research. Not so much of a focus on efficacy, but now looking at things that other stakeholders value. The first step to this implementation was training of the clinicians. That was quite an intensive process of them coming over to the Brain and Mind, observing the sessions, train the trainer sessions in the NEAR approach, the various exercises, provision of all the materials, and then on the other side, once they started, going over there to observe their sessions for fidelity and providing ongoing supervision. The initial pilot trial over 2 waves gave us an opportunity to really define the outcomes and the design, to establish the team, including a program champion, which was the neuropsychologist, Claudia, and to establish the logistics of how it would run. And over those 2 waves, we had some iterative adaptations, taking into account participant feedback on the language in the psychoeducation content and facilitator feedback on how many sessions to dedicate to each cognitive domain, etc. The results showed, in terms of that RE-AIM framework, that essentially it's quite feasible. I'm almost out of time, so I'm just going to go a little bit faster here. 1 more minute, Sharon. And we saw that all the recruitment strategy was feasible, efficacy, you can see in this table, acceptability and tolerability. This led us to a feasibility RCT. Very briefly, again, Claudia's results have shown that the program has been feasible to be implemented in this clinical setting. And some of the learnings, so the facilitators have been having a champion of the program, having motivated staff and patients, but the challenges have been the time that this process has taken, particularly with formative evaluation rather than the pragmatic approach, the cost, the organisational requirements, patients requiring transport, setting up the equipment, etc. I'll just finish off briefly to let you know we've got a new study also starting with implementing this trial in the Royal Prince Alfred Hospital with the Memory and Cognition Clinic. And so far the trial hasn't started, but we have had some learnings to date. Again, similar facilitators, a really collaborative team to give us some help into those different stakeholders and how we can address that with specific outcomes. And learning the language of public health as a clinical researcher has been a real learning for me. Okay, thank you. I'm going to stop there and hopefully talk to you more in discussion.
I'm very excited now to also introduce Dr. Kerryn Pike. So many of you, of course, will know Kerryn, and I certainly hear lots through the ADNeT network about people that have heard of Kerryn's work, or have experienced the LaTCH program in particular, with great reviews of the work that you've been doing there. So for those of you that don't know Kerryn is a neuropsychologist and senior research fellow at Trobe University in Melbourne, Her expertise is in ageing and dementia, and she's worked in this area for more than 15 years. And Kerryn's particularly interested in interventions, especially the cognitive interventions, to minimise the risk of developing dementia, as well as improve the quality of life and daily functioning in all populations. She's also really interested in how we translate these research findings regarding risk reduction and cognitive interventions into clinical practice. In terms of her research track record, she's has 53 papers in very high quality journals within psychology and neuroscience, which are highly cited, more than 5,500 citations, and a book chapter on Alzheimer's disease, prodromal stage and dementia. And she's attracted already over $5.9 million in research funding to date, which is fabulous. So Kerryn's going to talk us through her experience, and then we're going to have all the questions at the end. Thanks very much, Kerryn.
Okay, so I'm going to thank you, Loren, for setting us up and going through a bit of the background about what we're talking about with cognitive interventions and explaining the experience of the HBA program and what you've been doing up in Sydney. So I'm going to go through and talk a bit about the LaTCH program. I'm going to run you through the principles and the content behind that, go through the research and the evidence base fairly quickly, talk a bit about our experience with implementation for LaTCH, and then wrap us up for the session talking about kind of implementation in general and overall what Loren and I and the group that have been working together on this have sort of learned and where we're at now. And we would love the audience's comments and opinions on that when we get to that stage at the end. So this is LaTCH. So LaTCH just stands for Trobe and Caulfield Hospital. That's just who's developed it. So it has been developed by Glinda Kinsella and myself at La Trobe, together with Liz Mullally and Liz Rand, who I'm sure many of you are familiar with from Caulfield Hospital. And so it's a memory management group intervention, and you can see the research studies there. And I'll talk through them a bit later. So LaTCH, there's some overlap with the interventions Loren's talking about, but some differences as well. So LaTCH is always been a group program for older adults with subjective cognitive concerns or mild cognitive impairment. It's been run as a 6-week program for 2 hours a week, 6 to 12 people per week, and generally run by 2 experienced facilitators, or an experienced facilitator and co-facilitator. And it's a manualised program, but is meant to run in a semi-structured, sort of much more interactive format, where the manual just gives you an idea of the way that things are supposed to go along. It's very much based in a CBT kind of approach, where there's psychoeducation as well as teaching people skills and helping normalise ageing and memory changes as we get older, and the different causes for that. LaTCH has weekly handouts and covering the material for each week, and also homework assignments that people are supposed to do each week. And it provides information about memory and memory strategies and skills used very much in everyday life. So LaTCH is very much focused on memory in everyday life and how do we improve that. So the structure is based around topics of common everyday complaints. You can see the complaints there. I'm sure they're things that you've heard about from your clients. And pretty much each complaint almost takes a week or a topic. We cover one of these difficulties. And then we go through and use a process of thinking about, we start off and have some psychoeducation about understanding memory and providing some relatively simple models of how memory works, so that people, and what happens when you have memory slips, so people can get some idea of what sort of strategies might be most useful for their difficulties. The psychoeducation also includes information about what's normal, what sort of reasons there are for memory slips and that kind of thing. So people get a bit of a sense of what's going on for them. And then the specific strategies, we tend to focus a bit on things that are about preparing for remembering. So, identifying reducing risk factors, being confident about your memory and improving concentration, because if you don't take something in to begin with, then you can't really be expected to remember it. We then talk about strategies that actually just reduce memory load, so doing tasks straight away, using external aids, and using organisation, so you don't have to rely on your memory so much. And then we teach people specific internal strategies that have got good evidence base. So the strategies we mostly focus on are spaced retrieval, association and implementation intentions. And then we get them to practice. We demonstrate in session, we get them to practice in session, and we get them to practice at home and come back with the strategies. And one of the things, in some ways LaTCH seems very simple, and this is all information we all know and lots of the public, I guess, know and could find out on Google and so forth. But one of the reasons I think that LaTCH works well is because it's actually got a lot of behaviour change techniques underlying it. So sort of recent work by Kerryn and Mishi, etc., have identified different behaviour change techniques and the mechanisms of action for changing behaviour. And so I guess in terms of LaTCH, you're thinking about changing how people feel about their memory and how they might, what strategies and things they might use in everyday life with their memory. So sort of changing their automatic approach to just give up when they strike a memory problem and actually implement a strategy instead. And if you look at these behaviour change techniques, you can see that LaTCH includes behaviour change techniques linked to the idea about beliefs about capabilities, so improving how people, what they believe they're capable of. It also is linked to the mechanism of action about goals, so we help people set goals about what they want to do and review those goals and review the outcomes. And it's also linked to sort of behavioural regulation, so self-monitoring occurs because people do their homework and they come back and they talk about how it went or didn't went, so they're starting to watch their own behaviour in everyday life and see what might be changing there. Oh yeah, so I quickly wanted to go through, just so you can get a bit of a sense of how LaTCH works. I thought we'd go through what happens in a particular topic. So I picked names because that's one of the most common problems people come with, and we deal with it quite early in the program. So when we're dealing, the week that we deal with names, we start off and we have a quick brainstorm with participants about the different types of problems there are with names, because of course one of the things is that forgetting names isn't always the same problem. Sometimes it's about forgetting the name of someone you just met. Sometimes it's someone you've met several times and you're still having trouble taking their name in. Sometimes it might be a public figure that you should know, or, you know, maybe most embarrassingly, you run into someone at the supermarket and you just cannot bring their name to mind. So all of those examples have actually got different underlying issues. So we talk through with them about the different kinds of examples. We relate it back to a framework, you know, illustrating the problems in the context of a memory model. I'll show you that on the next slide. And then we help guide the participants in terms of what strategies would then be best to address the particular problem they're having. So here's the very simple memory strategy. I noticed, Loren, you had something very similar on your slides down the bottom there. So we call this the 3 R's. So they just, you know, taking information in, so registering it to begin with, retaining or holding on to it, and then retrieving it. So this is a simple way of how memory works. And by getting participants to help identify where their memory problem is, that allows them to put the appropriate strategies into place. And so we show them this memory model, and then we go through, there's a bunch of strategies you can use for remembering names, and none of them are better than anything else. It sort of depends on individual preferences. So we cover things like space retrieval, association, concentration, using name tags in, you know, situations like conferences, and staying calm and seeing if it comes back to you. So I wanted to just run through space retrieval quickly. If people aren't familiar with that, it's a very simple learning technique. And it relies on errorless learning, and it can be used even for people with very significant memory problems such as dementia to be able to learn simple amounts of information. So it's useful for things like names or passwords or PIN numbers, that sort of thing. And what you need to do with space retrieval is actively recall the information over progressively longer intervals. So I thought I'd do a quick demonstration so you get the hang of space retrieval. So this is what we do with space retrieval. You write down the information that you want to learn. So that might be the person's name, a PIN number, a password, a mobile phone number. Then you cover the information up. Then you say it to yourself without looking at it, right? So this is the active retrieval. The name I was trying to remember was, and then you actively retrieve that from your brain. And then the important step is you uncover and check whether you got it right or not. So remember, it's in the errorless learning group of strategies. So you need to try and make sure we're not introducing errors. Now, so first I want to go down the pathway. Yes, you got it right. You know, it was straight away, you've remembered the person's name. Great. So you've got it right. So you cover that name up again. And then you increase the time you're waiting until you retrieve it again. So you could do this formally with a stopwatch or on your mobile phone or something, or you could just do each ad as you're watching or each set of ads as you're watching a TV show. But you might say for 1 minute, and then after 1 minute, you go back through the process, you say it to yourself again, uncover and check whether you got it right. Again, if you're correct at 1 minute, you cover it up, and then you would increase the waiting time to 2 minutes. And then if you're still correct, to 4 minutes, and so on. There's no magic number that you need to get to that means you will have that information embedded in your head forever. It's a bit different for everybody, but you know, generally after about 4 or 5 minutes, it's pretty good. And then you'd stretch that out maybe to an hour, to 2 hours, to a day, to a week, that kind of thing, to keep doing the active retrieval. The other pathways, if you got the answer wrong at any time point. So if you could either not remember the information you were trying to remember or got something wrong about it when you checked, then you cover it back up, and then you need to reduce the delay interval. So you'd go back to the last amount of time where you've got that information correct. So maybe if you've been at a minute, you might go back to 30 seconds. And then you'd say it to yourself at 30 seconds and uncover and check whether you got it right. If you got it right, then you'd go back to a minute again and keep going that way. If you got it wrong, then you'd shorten the interval. So hopefully that gives you a bit of a sense of spaced retrieval. So it's a relatively easy little technique, although, you know, it can take a bit of time. When you're teaching it to people, it's good to sort of demonstrate this to them in session, get them to have a go themselves, get them to have a go at home, and then try it with lots of different material. And by the end of, you know, a 6-week LaTCH program, people are doing really well with this particular technique if it's something that they like. But it does take that little bit of demonstration and practice, I think, for people to take it on board and some success to see that they can actually learn information doing this. Okay, so that was a bit of a sense so you've got an idea about what LaTCH is. Now I wanted to run through the research evidence for LaTCH. So this has been published. We did an RCT with NHMRC funding several years ago. It was good quality has been included in Peterson's MCI practice guideline update. And so we'd had about 100 people with amnestic MCI and 100 healthy older adults enrolled in the trial. You can see that they were well matched on sort of education IQ. The people with MCI were a bit less likely to be women, and they're a bit older, and their cognition was worse, as you would expect. And this was our RCT design. So it was a randomised controlled trial wait list. So people were they came in, they did their pre-assessment and screening. They were either randomised to get the group straight away or in a little while, in about 8 weeks' time. And so the results I'll be talking about today are from this post-early assessment where the early people have had the intervention and the wait list haven't had it yet. And so I'll quickly run through the results just to show you where the program was showed that it was effective. So one of the areas we looked at was strategy knowledge, so whether people could tell us about different strategies that would be useful in different situations. You can see an example here. And what you can see in the results is the blue is our early group, so these are the people who've had the intervention at this time point. The red is the people who haven't yet had the intervention. You've got your healthy older adults here, you've got your older adults with MCI over here. And for both groups at this point, the intervention has had an effect, so it has improved their strategy knowledge significantly. Similarly, for strategy use, this graph's actually just showing us our internal strategy use, so things like association, spaced retrieval, that sort of thing. And again, you can see that the interventions had an effect for both healthy older adults and for people with MCI. I've just put a note here that healthy older adults also improved on external strategy use, but MCI actually only showed an improvement on the internal strategy use. And then this is their confidence about their memory. So you can see some examples here, how settled they're feeling with their memory and their sort of efficacy about that. And again, you can see for both healthy older adults and people with MCI that they felt better about their memory, the people who had done the intervention versus those who were still on the wait list. Interestingly, we also looked at memory ability, so looking at results on a well-known test of learning and memory, the CVLT. And here we didn't find any differences between the people who had the intervention and not. So it LaTCH didn't work to change memory ability on test performance. Healthy older adults do show differences when they self-rate their memory ability, but not people with MCI. And we did find when we look at our 6 months gains, that is maintained by healthy older adults, but not by people with MCI. Just continuing on with the evidence base, that we often sort of felt that we were sort of missing something important. This evidence didn't always capture all the really important outcomes. And so one of our doctoral students, Melinda Matthews, led a project a few years ago, which actually did a 5-year follow-up of people who'd done the original RCT. And we went and did some qualitative research with them and actually asked them about what was the most significant changes following the memory group. And then we, sorted this into themes and saw what came out. And so this gave us, some of the expected themes that had come out with the RCT as well. We know their knowledge and use of memory strategies improved and how they felt about their memory had improved, and we saw that on the questionnaires. But then we were able to also see that there were some things people were getting out of it that hadn't been captured by any of those other measures. So there was more acceptance about their current memory function and what that meant. There was reduced carer stress, so their family members felt less worried about caring for their loved one. And lots of people sort of reported this idea of the shared experience or not being the only person in this situation was really important. And you can see a little quote here from a man with MCI who was part of the group. And he's sort of talking about, for him, that the most significant thing that he got from doing the group was realising that there were other people who were experiencing similar difficulties, and he wasn't the only one with that. So I think that's all the sort of basic evidence base for LaTCH. So I wanted to talk a little bit about our implementation work that we've been doing with LaTCH. So we've done this sort of with 4 organisations so far. One of them is actually in progress. So we've done some work with Dementia Australia, so a community-based organisation, to implement LaTCH in their service in Victoria. We've also worked with Caulfield Hospital and the community rehab team, and with Ballarat Health Service CADMS, and we're currently submitting ethics to look at implementation of Peninsula Health Service, the SACS and the mental health. So I thought I'd quickly talk through these in terms of the process used and the evaluation and what we've learnt about that. So firstly, with Dementia Australia, so again, this is published, so you can go and have a look at that if you want a few more details. I guess the first thing to say is we've been a bit pragmatic in our implementations and not used a formal framework. With Dementia Australia, we had an existing relationship with them, sort of at the management level. And so, you know, speaking with them, there was quite a good fit. They already ran groups for people with dementia and their families. They were really interested in trying to offer something for people with MCI, and they thought the LaTCH program could be good. So we sort of, you know, had this joint interest together. We worked with them to run LaTCH through their organisation. We essentially didn't have to really make any changes to the program format or content. We did, you know, the training process was fairly extensive. We had introductory workshops. We had a very detailed manual for the facilitators, and then we ran co-leadership training initially. So a trained facilitator of LaTCH would run it with someone from Dementia Australia who was being trained up, and then the person from Dementia Australia ran the group with the LaTCH person there as well, sort of for backup. And then once people were sort of happy that they were able to run the group, then they trained other people within Dementia Australia as a you know, co-facilitated. Co-leadership model wasn't really cost effective for a long time. And then we did annual evaluation of the fidelity of the programs. So we managed to train 7 Dementia Australia staff, and they've, at the time of publication, they delivered 30 groups, and you can see almost 300 people with MCI had attended these groups. So in terms of the evaluation of the implementation, initially we wanted to look at quantitative assessment questionnaires and goals, but unfortunately it was a very low response rate, and I'll talk about that a bit more in a second. So we ended up focusing on the qualitative interviews, which was similar to what Melinda had done in the RCT. And we got similar themes in the RCT, so making us feel, yes, it was that the implementation had worked and was giving the MCI participants similar outcomes at Dementia Australia as they'd had in the RCT. And we also found the facilitators of LaTCH had some changes in their practice that you can see there too. We then asked staff, so if we think about implementation, we asked staff more about the barriers and enabling factors for the implementation of Dementia Australia. And so they came up with some really interesting things. So, you know, they talked about enabling factors were about the good organisational fit, but, you know, there were challenges in terms of staff turnover and the amount of training that might needed to be provided and who had to do that training and the time for that. There was also the administrative demands in terms of the evaluations and in terms of screening people and getting them into the thing. You can see in terms of the client cohorts, so there were some comments about screening clients who's suitable for the service, difficulties with getting people travelling, you know, to get there, and the regional service. And the manualised program, while there was some good things about having that, sometimes they weren't sure how flexible they could be about that. That was the Dementia Australia. Sharon, I've got a few more. I don't know if you've popped on because we're time. I'll scoot through the last bit. So these are just some of our learnings in terms of LaTCH at other Victorian public health services. So you can kind of see there in terms of the different services at different places. You know, we've had different people who've been in charge of running the facilitating the groups. We've had different people who've been our key contact, and we've had different learnings sort of come out in terms of how important it is to have a change champion, someone who's really keen for the program on site. This can be especially useful, I think, if it's someone in management. Different health services will be able to put this in different places. The resource demands are always tricky to negotiate. And something that will come out later is the different knowledge base of researchers, clinicians and managers. All right, I'm not going to go into this in too much detail, but just to say, if we're thinking about, so I'm moving on to general implementation science now. If we're thinking about it, there's lots of different frameworks. There's no real consistency about what framework to use. But yeah, there are frameworks there that are important to be aware of. And you can see here, one of them is the RE-AIM framework that Loren was speaking about before, but they cover the process from describing and guiding the process of implementation through to understanding or explaining what kinds of influences are there through to actually the evaluation of your implementation. And when we have a quick look about implementation studies around the world, really there's been very few studies published either in Australia or internationally. So Loren and I have described our experiences today. We have been working with Sharon as well as a group of other researchers who are really interested in this in Australia. So Catherine, Amit, Alex and Claudia have all been involved. And we've been talking about what the challenges are to implementation in Australia and how we might go ahead with this. There's a couple of implementation studies around the world that have just recently been published. Again, these aren't really about cognitive interventions for the group we're interested in. The first one's more about a tool to decide what sort of non-pharmacological interventions you might use for people with dementia. The second one here by Ing is in Singapore, where they actually have run, it was a multi-domain dementia prevention study, which included some cognitive training. So it was sort of interesting, but they didn't actually get any effects on their cognitive training. And so I'm just sort of moving here to the last couple of slides to think about the considerations. So from the work that Loren and I have done, from the international work and so forth. So we've got some ideas here. We don't have answers for all of this, but one of the key things you need to consider with implementation is the different stakeholders, you know, researchers, clinicians, service providers, policymakers, and of course the clients and their family members. All these people are sort of more interested in different outcomes. They all come with different lenses. They may have different skills and different knowledge to offer, but also knowledge gaps. So as researchers, Loren and I have sort of reflected that we often don't know a lot about how specific health services operate, and we need that information from clinicians. But then clinicians don't always have the time and the knowledge about regulatory processes like like ethics applications and other things. So it's good. So probably we need all these groups involved working together when doing these interventions. Client factors are important to think about. So the best way to access the intervention, if it's going to be community centre or hospital, you know, Loren ran through, they've tried lots of different things, you know, online, computerised, in person, group models or individual models. You know, thinking about diagnosis, what intervention and what access will be appropriate depending on if the person's a healthy older adult, MCI, dementia. Cultural factors, how much you're going to include support people. Clinician factors, who's going to run it, what training do they need, and then what training do they need coming in, and then what training do you need to provide for them. You know, the motivation, how excited people are to run this. If this, you know, does this feel like something that they want to do and progress in their career, or does this feel like extra work someone's getting them to do? Service level factors, how does it fit with your organisation? How are we going to measure cost effectiveness? You know, how do we fit interventions in when people are already got full caseloads? Who's going to pay for it? Does this fit in with the, you know, is this funded by the service or do individuals pay for it themselves? How's that going to work? And as I noted, change champions. They might be at the service level or they might be at the clinician level, but they're key people, I think, with these implementations.
Kerryn, we'll have to wrap up, sorry, because we've only got 5 minutes left. Sure,
Sharon. I think intervention process and evaluation, and so I just want to then sort of pop on to the way forward, you know, how we go forward from this, which was we wanted to get some audience input, thinking about, you know, ADNeT might provide us with an opportunity to explore these interventions in a nationwide setting. I should just acknowledge everyone, and there's references in the slides which people can see later if they want.
Just while we get organised, and there is a question in the chat about that very issue, Kerryn, how do we do it? And is it something we can think about implementing throughout the ADNeT memory clinics? And on that note, when we did a survey, we actually found that only 20% of memory clinics were able to offer memory strategy training interventions, and even less, 1.8% of the 55 respondents said they were able to offer computerised cognitive training. And I think one of the main barriers is resources. And I guess I wondered, you know, what your thoughts are on how, you know, what the best way we could think about doing this with existing resources. Is it something that neuropsychologists have to do? And if so, which bit do they do? And can we also involve other allied health, for example, in this process? Just a quick answer, because we've got some other ones coming up.
Yeah. Look, I think that's quite tricky, and so it depends on the service. I think, you know, the cognitive intervention sort of fits in. This is what neuropsychologists, this is sort of neuropsychologists' domain, and they want to be involved in that, but sometimes it's not always practical. So I think maybe it's with neuropsychology supervision in some cases, or look at how workloads can be shuffled around so that people can get the opportunity to do some of this work. Yeah,
yeah. And so one of the questions is, you know, can we come up with some kind of standardized criteria for the provision and delivery of therapy across memory clinics? Perhaps ADNeT can facilitate that, but is that something that you might be interested in doing, perhaps with the broader group you mentioned, Kerryn and Alex and Amit? Is that something that we could tackle at a national level?
Yep, certainly, Sharon. That's definitely something that we're thinking about. And one of the things I think we would have to work out before we can prescribe this one-size-fits-all approach are some of those patient-related factors, service-related factors. And so initially there would have to be some kind of participatory design approach, focus groups to find out, you know, how the services might operate across different settings, what parameters they can offer, you know, what the clients want, what are the most common client groups that are seen in those settings. So it's certainly something that we can work towards, but a lot of work has to go into it collaboratively. And we're hoping ADNeT can facilitate that.
Yeah, we would love to. We have a question also from Michael Woodward. How well does a program like LaTCH work with CALD? Do we need to do some more work there to adapt these kinds of programs for CALD groups?
Yeah, potentially. There hasn't been any, we haven't done any specific studies with CALD groups for LaTCH. It's been something we would have liked to have done, but again, we can't really answer that yet because we haven't adapted it. Yeah.
And also another question about, similar to medication doses, do we know from the literature yet if there's a dose or how many weeks someone needs to do cognitive interventions, either memory strategy training or computerized training for it to be effective? And does that differ by, you know, MCI stage versus different stages of dementia?
Certainly some of the meta-analyses that I was referencing in my talk have shown some of those moderators of the effects. It seems to be that, as I said earlier, no more than 3 sessions a week confer any additional benefit. Shorter sessions of around half an hour to an hour seem to be appropriate. The duration of the program is a little bit up in the air. Some studies have used 10 weeks, some 20 weeks. Certainly we know the evidence shows that booster sessions after cessation of the program, after a period of a few months with no training, can be quite helpful to augment the effects. But again, I think it depends very much on the population that you're working with and the parameters that they're prepared to commit to. And
I can see we have a question from Wendy Longley, but it's not actually showing up. But it made me think about Wendy's program that she's running, and that's actually kind of tailored very differently to people with dementia. Do you think we need to have a different approach for people with MCI and people with dementia?
Yes.
Yes, very much so.
Yeah.
I think the literature shows that different approaches are appropriate for those different groups, and certainly we know that people with dementia versus people with MCI or healthy older adults are likely to engage differently as well and have different needs in terms of whether we're targeting the activities that they're participating in versus those, you know, basic activities of daily living, for example. So yes, wholeheartedly, very different approach. And that
you just made a point that there are also lots of other non-cognitive issues that need to be addressed in those groups as well.
And that's one of the difficulties with prescribing a standardized intervention across memory clinics. We have to take into account all of these issues.
Yeah, okay. Look, we've run out of time. I've got a couple more. If people need to leave, by all means do, but someone's just asked about lumosity. Do you have any thoughts about this? Is it of benefit? Would you recommend it?
So look, my individual kind of approach to things like that is to say that there isn't really good evidence that a particular brain training program is going to help people with their difficulties in everyday life. So I sort of often talk about the difficulties with generalising those sorts of programs to everyday life. So You know, if people enjoy doing that sort of work, then it's really important to keep your brain active, and Mowszowski could be a good thing. It's probably one of the best ones of the brain training programs. But if they want help with remembering names in their everyday life, the Mowszowski is probably not going to help with that. So it's what they want to spend their time doing. So that's my personal way of talking about it.
The other thing that we often find with the computer-based programs is adherence. So people tend to get really excited about them at the beginning and do them, you know, quite religiously, and then that sort of tapers off. And then they wonder why they're getting no benefit. So adherence over time can be a barrier to, you know, any benefits there.
Yeah. Okay. And look, just while I'm getting the slides on to wrap up, maybe you could just answer the question about, could this kind of thing be run in a payment setting, such as, you know, not for profit, but people could pay to participate in these kinds of programs?
I think potentially. So maybe I should have mentioned, actually with Dementia Australia, they've ended up, they had a co-payment for patients in the later phases of that. So yes, I'm not sure. I think it'll be tricky with the cost. It'll be tricky to recoup your entire costs from payment from individuals, because I think it would be quite expensive for people. But yeah, maybe in a co-payment kind of model. I don't know
certainly with CogMax, you know, the approach that we're trying to show with the one-on-one facilitated sessions, it's potentially something that individual clinicians could offer as part of their, you know, their range of therapeutic services in a fee-based model.
Yeah, yeah. Okay, well, it seems like we've got a lot more work still to do with this space to implement it more broadly, but I think we've got a very engaged community that would like to see it implemented in the memory clinic setting, and I do hope we can help with that via. I'd like to thank you both, Kerryn and Loren, for excellent presentations. We've had some great feedback in the chat as well. And again, for those of you that may have missed some of it or have other colleagues that would like to have a look at it, then please check it out on the YouTube channel that Joe put in the chat. Just a quick plug for a seminar that's happening at Chiba, or webinar I should say, next Wednesday. Carol Brain, who's an excellent speaker and doing some great work in the field of dementia prevention. So please see the link there if you're interested in participating in that. And just moving along. We mentioned at the beginning we have a feedback survey and certificates that will also automatically come up at the end, so please stay online and give us your thoughts about the presentation and any suggestions for future topics, and we'll send you the certificate via email. And if you have any other questions about the ADNeT Memory Clinics initiative, or indeed the Clinical Quality Registry, then please feel free to reach out to us, and we'll do what we can to help answer your questions and become part of this national initiative, which we're very proud of. So thanks again, and we look forward to seeing you at our next webinar, which will be in June. We're just finalising the details of that, but we'll put them out through the usual channels and social media in due course. So thanks very much, and please join me in thanking our wonderful speakers.